So much. Thank you everybody for having me. My name is Rebekah Fayette. I'm a certified nurse midwife and a psychiatric nurse practitioner here in Boise, Idaho. I've been in practice in the Treasure Valley for over a decade, and my focus obviously is primarily on women's health throughout the lifespan, with a special interest in that reproductive medicine and then also in psychiatry. Um, if anybody has any questions throughout, I kind of like a little bit of a fluid session. I know that my time is relatively limited, so I'll try to be courteous of that for our next presenter. But if something pops up and there's something of interest, let me know and we can kind of talk throughout. A lot of this is the way that I practice, and so some of these things might be different from maybe the way that you would practice or from what you would see. So conversation is always key. And if you have questions, we'll go ahead and do that. So our topic today is the hormonal impacts of mental health during perimenopause and menopause. Next slide, please. Some of our learning objectives. I know it seems pretty self-explanatory, but I just want to put it out there. What is the definition or kind of the determinants for perimenopause and menopause? Impacts of hormones on mental health throughout these transitional periods for women, and then potential treatment options and factors to consider. Next slide, please. When we're discussing perimenopause and menopause, I think it's helpful to understand those transitional phases and where a woman might be. So when we're discussing perimenopause, we're looking at the 5 to 10 years leading up to the last menstrual period. That average age of the last menstrual period in the United States right now is 51 and a half. So these are women who are in that 40-year range, so about 40 years of age up to about 50. During this time, we're seeing major fluctuations in hormonal changes. So women can come in and have a variety of different symptoms. It can be something as relatively insignificant as having cavities or having mouth changes to having hair changes, skin changes, energy changes. Some of the most common things that we'll hear about is hot flashes or night sweats, weight gain, and then mood disturbances. And then something to just kind of think on, we see a lot of people getting a lot of lab work during this time, and there isn't any diagnostic test that says a woman is in perimenopause if you have an estrogen level or a progesterone level at this point, because it's a moving target. Many of these women are still cycling during this time, even if they've had surgical menopause where they've had their uterus and cervix removed, tubes removed, but their ovaries were spared. We're still having some hormonal disruption that can happen there. So there doesn't have to be lab work in order to say, hey, this woman might be having some issues during this time and we want to go ahead and treat something. Menopause is that menstrual period cessation that goes for 12 consecutive months. So we go 12 months with no period, and then we're in that menopausal phase. Again, average age is the age of 51 and a half in the United States currently, and this signifies the end where we have outlived our ovarian production, and this is accompanied by that reduction in hormones. And a lot of women are going to experience a lot of different symptoms during this time. Next slide, please. Some special considerations. Symptoms can vary significantly from one individual to the next. So again, that's where you'll have that woman come in with very vague symptoms. So she might just say, I feel like my depression has been relatively well controlled on my antidepressant, and now all of a sudden I don't feel like it's controlled anymore. That might be somebody who's having some hormonal disruption, and maybe we need to consider something for her, all the way to the woman who's having a disruption in her bleeding and having hormonal changes in terms of hot flashes and night sweats, weight gain and energy levels, and things that are more specific to that menopausal phase that people are really familiar with. The combination of all of these symptoms really impacts daily functioning for women, their relationships with their friends, family, and peers, and their overall quality of life. And that's why so many women are coming to primary care, women's health specialists, mental health providers to seek out alternative options for treatment, because they'll say, I just don't feel normal. And I can't put my finger on it, but I know something is not right. Life expectancy for women today is around the age of 82. And I think that's a big reason why a lot of the research that we have now is more up to date recently versus many years ago. We weren't living to the 80s. We were dying very young following childbirth. And so we may not have even reached that menopausal phase or the perimenopausal phase of life. So I think now, as we're living longer, we really have to take that into consideration for women. And women will spend 1/3 of their lives in that postmenopausal stage of life. And I think that's very thought-provoking when we look at cardiovascular changes for women, osteoporotic changes for women, and dementia-related changes for women. Estimated by the Women's Health Organization, the number of postmenopausal women will reach 1.2 billion by 2030 globally, with 47 million women entering menopause every year. I think that's just a huge number to look at. So there's a lot of us that are out there. And then some groups of women who appear to be at a much higher risk for developing mood disturbances. We're going to look at those women who previously have been diagnosed with depression, anxiety, PTSD, OCD, ADHD. Women who have had mental health disruption during the perinatal phase, so during pregnancy, and in the postpartum phase. We notice that there is a much more challenging time during the perimenopause and menopausal transition, so we want to be aware of those women. And then endocrine disorders, so PCOS, primary ovarian insufficiency, hypothyroidism, other disorders that are endocrine related. We really want to keep those women on our radar as well. Next slide, please. Hormonal changes and the impact on mental health. So when we really look at the women who are coming into us, 70% of women are coming in with mood disturbances. So they'll come in and say, I feel anxious. I can't sleep. I cannot function. I feel like my brain is foggy. My concentration is poor. I wonder if I have this. So a lot of women are doing some self-diagnostics, if you will. They're doing Google searches and looking because they feel mental disruptions first. It's not always the hot flashes and the weight gain and some of the other things that people are more prone to report to a primary care or another healthcare provider when it comes to this phase of life. Rather than that overt sadness in women that could be very specific to a depressive symptom, women will report things like, I feel irritable, I feel edgy, a lot of my irritation is toward my partner or my children, that anhedonia or just that lack of pleasure. I just feel kind of flat. I don't feel like I have a lot of energy. Those can often be mistaken for just normal aging. So I have a lot of women that will come in and say, I felt dismissed because I went in and saw whatever provider I saw. And they said, oh, that's just normal. You're getting older. Try to do this, try to do that, drink water, take vitamins, go for a walk, get sunshine. And many women have done a lot of those things already and now are coming to seek additional support and are feeling like they don't know where to go next. So as we're getting into hormones, it is a mouthful. I'll try to make it as easy to understand as possible. So I want you to think of estrogen like your flexibility hormone. So when we think of estrogen, it provides flexibility through our whole body, not just bending down and touching your toes, but being able to have flexibility within our heart so that the vessels coming in and out of our heart don't get plaque buildup or get stiff and inflexible. Flexibility within our brain so that we're able to concentrate, have good memory, and then have good mood regulations because there's parts of the brain that run on estrogen and are very estrogen specific. When we think of flexibility throughout our body in terms of our muscles and our skeletal system, we're looking at that flexibility in our joints and our ability for our skin to flex and contract. And so it makes a lot of sense why women will have a lot of symptoms related to stiffness, joint pain, headaches, temperature fluctuations related to some of that estrogen change. So as we're having that decline in estrogen, we can see that mood fluctuation. So that's that irritable edginess, the anxiety, or the sudden shift in emotional change. There can be increased risk for depression during this time. So there's a lot of studies that indicate that women are at a higher risk for depression in the perimenopausal phase and then immediately following that menopausal transition because it's such a stark contrast in the amount of hormones that are coming in and coming out. Next slide, please. When we think of progesterone, I want it to be focused on as more than just endometrial protection, because that's very, very valuable and super important, but also looking at it as our mental health hormone. So as we're bringing that progesterone into our brain, it helps to regulate that mood. It's sedating, so it can help to promote sleep. And as we're having a decrease in that progesterone level, we can see a lot of sleep disturbances for women. So a lot of women will come in and say, I'm either having trouble turning my brain off, falling asleep and or being able to stay asleep or feeling a lot of fatigue during the day. There can be, obviously, when we don't sleep well, we all kind of know this, you wake up, you feel a little bit more edgy, irritable, our bandwidth is a little bit more limited. And then we can have a real big increase in anxiety when that progesterone drops. Next slide, please. Cognitive changes are a big one. So obviously many women will report this phenomenon of brain fog, and that's kind of that executive dysfunction for women in that perimenopausal phase. So this is like concentration, memory, and just cognitive processing. So women will say, I used to be able to have a photographic memory. I would hear something or see something and remember it. And now I feel like things are just dimmer. My thought process is not as crisp and clear. I feel like I'm having more issues with forgetfulness. And many of us are in high profile jobs. We have a lot of different responsibilities. And when you feel like this is occurring, it can really make you second guess your ability to continue to practice the way that you do and function in the settings that you do, and really lead to a sense of frustration, increased stress, worsened mental clarity. So again, feeling like our overall quality of life is not good, our daily tasks are being impacted, and our just overall sense of self is really diminished. Next slide, please. Physical symptoms and self-perceptions, I think, are super valuable and really important to talk about, and that's why I wanted to kind of make it a slide all in and of itself. Those hormonal changes that women are experiencing, and we do this several times in our life. And men, I'm not discounting you, but this topic is real specific to the women in the crowd out there. We go through a major change during puberty, a major change again anytime we conceive a pregnancy. Even if you were to miscarry and not carry a pregnancy to full term, you're still having a major fluctuations in hormones, and it takes a whole year for your hormones to recover following a pregnancy. So it's interesting that we have 12 months or 12 weeks that we're off in the postpartum phase, but it takes us 12 months to be able to recover hormonally. So kind of keep that in the back of your mind when we're looking at some of those hormonal changes. And then again, in that perimenopause and menopausal phase, those big fluctuation changes. During that time, physical symptoms that we'll see, many women will come in, and I'm sure all of you who are on here have heard some woman say, I feel like I'm having hot flashes during the day. I'm having hot, night sweats at night. I'm gaining weight in my midsection. My skin is looking different than it used to. My hair is falling out. My nails have changed. And this can really lead to body image complexes, self-esteem issues, feeling like we want something to help to fix the way we're feeling, because everyone sees us and who we are when you're presenting yourself forward, and that may not be the person that you're actually feeling like inside. And isolation is huge. If I feel like my weight has fluctuated, I'm not interested in going out with people because I don't want someone to say something to me. Or if I'm exercising just as much as I always have, but I'm not able to lose weight, or I'm not eating any differently and I'm not able to lose weight, then there's that sense of maybe I'm not in control. Maybe I don't take my health a priority the way that I should. And this can lead to women withdrawing from things that they typically enjoy doing, social activities, or just feeling very lonely or sad. And Candace and I both see this a lot, women coming in and saying, I feel like my community is dwindling. The number of people that I share things with is starting to get smaller because they just feel like they don't know what to do. Next slide, please. Managing mental health during perimenopause and menopause. So, number one, seeking professional support. Obviously, I am not the first person that many people will see when they have a history of premenstrual dysphoric disorder, generalized anxiety, major depressive disorder, ADD and ADHD, obsessive compulsive disorder, or even PTSD. A lot of primary care providers are kind of the first line. Someone will come in and say, I feel XYZ. So it's really important to know that while we're talking about hormonal fluctuation and the different hormonal components to mental health, it's super important to realize that sometimes it is just mental health, and we have to focus on that. It doesn't have to be one or the other, but knowing that they're very closely related. So when it comes to things like treatment options, I know that there were some questions, potentially, are we going to talk about treatment options? I have different things that I use in my practice because women are all I see all the time. So I have things that I feel tried and true for me. And so, for example, if I'm looking at someone who has PMDD, which is more than just PMS, this is for someone who has significant hormonal disruption and mental health disturbances about that week to 10 to 14 days leading up to the last menstrual period during their cycle. I typically will treat that with an SSRI versus immediately jumping into something like a birth control pill, because that doesn't necessarily address the level of concern for women. You can do luteal phase management, or you can do continuous phase management. So luteal phase is where we're only treating during that time of exacerbation. So let's say that Shannon McDowell comes in to see us and she says that I know on day 10 of my cycle through day 17 of my cycle, I am super sensitive. I'm very upset. I feel very emotional. I feel disconnected. Everyone is my enemy. And I just can't maintain. You can take an SSRI during that time for only those 7 days and then discontinue that medication. The medication I typically use is fluoxetine or Prozac. I find that that works very well for women that I'm seeing in my practice in different phases of life. And so that's typically what I'm using in my practice. I take into consideration when we're looking at medications. And again, if this kind of goes down that mental health perspective, and if some of these things are coming up and are kind of confusing to you, again, please reach out to me and I'm happy to go over different recommendations that people might have or questions they might have. I try to take into consideration the three biggest concerns that women are going to have when they're starting a medication. Am I going to have sexual side effects? Am I going to gain weight? And am I going to change my emotional state? So typically when I see things like sertraline or Zoloft used in my practice, and you might have a differing opinion out there, I will have a woman come in and say, I gained a bunch of weight when I was on it. I felt super flat and I felt like I wasn't emotional anymore, but then I just had no emotion. Or I had zero libido and I already am having that age-related concern. So that's a no-go for me. So having that conversation, trying to pick medications that are weight neutral and or sexual side effect neutral. And that's pretty specific to men and women as well. So PMDD, that's a big one. GAD, generalized anxiety. This is just that overwhelming sense of anxiety. Most days, every single day, kind of describe that person as a worrier. Again, you can use fluoxetine. You could use something like escitalopram or Lexapro is relatively well tolerated if you're doing SSRIs, so a selective serotonin reuptake inhibitor. All of those would be FDA approved and can be generally well tolerated during any of these different conditions. My one ask to you and the other mental health providers out there might have a differing opinion, but what I find is women who've been started on sertraline or Zoloft or venlafaxine or Effexor are the ones who are going to come in with the most amount of side effects and are the most challenging to taper off of. So I see a lot of women who will come in and say, I tried to take myself off that medicine and it was awful for me. I ended up in the ER, I had chest pain, I had anxiety, I felt really, really terrible. And I know traditionally Zoloft is deemed or sertraline is deemed to be super safe. A lot of studies that are done on it, but just because it's got a lot of research on it doesn't necessarily mean it might be the best. So dip into your tool bag and maybe use a different SSRI that's out there. And then in terms of Effexor or venlafaxine, I know that that traditionally is used a lot for hot flashes. And I encourage you to potentially seek out my partner Candace over here. We're laughing. Maybe try some estrogen for that versus immediately going to that venlafaxine because the side effects can sometimes be much worse than the hot flash itself. And so maybe again, dipping into our tool bag and looking at something a little bit different. In terms of therapy, one of the most specific therapies that has been out there and has been studied the most is cognitive behavioral therapy. So if you have somebody who's got underlying mental health concerns and they're really, really worried about starting a medication, cognitive behavioral therapy can be very, very helpful, can really help with reframing and changing negative thought processes. And I think everybody benefits from therapy, not just talking to our spouses or our friends. When we're considering hormone-based replacement therapy, we obviously have to have the right person in the right condition. So if I had, if Tara Whitaker came to me and she's 22 years old and says, my hormones are out of whack, I need HRT, I might have more questions for her. That's not necessarily somebody that I'm going to be starting on, but if I have Rachel Root, who comes in and says, here I am, Rachel, I know this isn't your age, but just play with me here. I'm 49 and I've got hormonal changes and hot flashes and mood disturbances and I can't sleep and it's really affecting my ability to be able to be a psychologist. Then I might say, hey, let's go ahead and go over risks, alternatives, and benefits for starting something and let's have a conversation about it. Let's not make it hard for people to access this. There's a lot of good efficacy and safety profile that's out there. The FDA removed that black box warning on vaginal-based estrogen products at the end of last year, so that should encourage us to feel confident in prescribing that. So when we look at HRT, I won't go into all the specifics because that's not what this is for, but I want you to at least know what some of the options are. So if you have somebody who, let's say, has depression and they've been very well controlled with their current medication regimen, but now they're starting to slip, potentially starting some estrogen for them might be valuable if they're a candidate for that. And there are some risks to starting estrogen for certain individuals, and you would want to be aware of what some of those risks are. We look at information through the Menopause Society, through the American College of Obstetrics and Gynecology. So we want to do evidence-based medicine that is FDA approved and cost effective so that it's accessible to everyone and not just the people who can afford it. So, talking about estrogen replacement, whether that be patch form, which is preferred because it bypasses that liver, so we're getting less side effects and getting better absorption, or potentially someone needing to be on a pill for a different reason. Micronized progesterone is intended to be taken orally. It's at bedtime again. It's that good anti-anxiolytic medication. So if we're somebody that's got the squirrel brain at night, we can't fall asleep, can't stay asleep, or we're having issues with irritability, kind of that edginess throughout the day, that individual might be a very successful candidate on progesterone. And pretty much everyone is a good candidate for progesterone-based therapy. So you could feel safe potentially offering that to somebody. It's sedating, take it at bedtime. It works on the GABA receptors in our brain, and that's that kind of brake system. So when we're kind of spiraling down, as many of us can do, it can kind of help shut some of that down. And then that vaginal estrogen, it's commercial grade, your insurance covers it. I give it out to all sorts of different individuals because it can be used for a variety of different people for all sorts of different concerns. And I might try something like that. Brian, I'm taking a look, I'm trying to look through some of the chat as it's popping up, so I apologize. I'm gonna pause for just a second. So Brian said, given lower sexual side effect rates for vilazodone and for, don't want that one. Do you use them often? Yes, I do. I do use vilazodone, I would say, really quite often. So vilazodone and paroxetine is your Trintellix and Vibrid. I love them. They're serotonin modulators. The problem with those medications specifically, at least that I find, super expensive and really hard to get covered at a very cost-effective rate. That would be my number one reason why I don't use it as often as I would like to. I certainly find that vilazodone or the Vibrid is covered a lot easier than the Trintellix is because it doesn't have a generic. There's a savings card, but even so, that can be really expensive for a lot of people. But I do really enjoy those two medications. So thanks for bringing that up, Brian. Kate Murphy asked, does the luteal phase dosing give SSRI enough time to build in the system and be effective? Yes, because it doesn't have to build up the same way that it does if you're treating traditional anxiety or major depression, OCD, or another condition like that. It can be started and stopped without having that withdrawal phase that a lot of people will experience if you, let's say, we're on a medication every single day and we're taking it for 1, 2, 3, 4 months and then just immediately discontinued it, you're going to get that withdrawal symptom that you're going to experience. I find a lot of people are super successful with doing just luteal phase management. So for me, if I'm doing fluoxetine, I would do 20 milligrams of fluoxetine and I would do that for whatever their phase might be. So if they say day 10 to day 17 or day 10 to 14, whatever that looks like for them, they take it just during that period of time. And the research shows very effective at symptom management, even when you're doing it just periodically like that. Thanks for that question, Kate. Next slide, Shannon. Okay, Catherine Fleming. Do you ever prescribe stimulants like Vyvanse? I absolutely do, and I knew someone was going to bring that up, so thank you for that segue. So let's be honest, everybody has a level of ADHD, right? We all have a level of executive dysfunction at one time or another. So when it comes to stimulants, I will say I am somewhat of a purist. I want there to be some reason rather than just, I think I have this. So I will oftentimes look at that overall, let's say that someone comes in, let me pick on somebody else. Who else is out here? Jeremy, we're going to pretend that you're a female. So Jeremy comes in to see me. Sorry, Jeremy, I hope that's not offensive. Jeremy comes in to see me and says, I'm 45 years old. I've been having hot flashes and mood changes and a lot of different disruptions, and this is what I'm experiencing. If you're coming in for perimenopausal relief, I am going to address perimenopausal relief. I'm not immediately going to say, has anybody ever said that maybe you have ADD or ADHD? So I want to focus on what that issue is that the person is presenting for. But my partner Candace can attest to this. There are many women that will come in that she will begin HRT on, or hormone-based replacement therapy. And then she'll say, you know what, I'd like you to come over and see my partner, Rebekah, and let's go ahead and do an evaluation for ADD and ADHD. So I do try to treat one versus the other and then one versus the other, because I think you can really get down into the weeds if we aren't effectively treating the concern that the person is coming in for. So yes, I use Vyvanse a lot. Again, I only treat women, so my niche is very specific. I think that Vyvanse or I think that it works, lisdexamfetamine, I think it works very well in women. I use much more lisdexamfetamine or Vyvanse than I do use Adderall in my practice. And I think that's just anecdotal. I've seen, the type of women that I have coming in and what their comorbid conditions are. And I find that Vyvanse can be very successful. But I like to kind of know what is happening. So it's not just I can't focus. I want more information when it comes to stimulants because I feel like they get doled out all over the place. I have people coming in on stimulants and I'm like, why did they start you on this? They didn't address that this is actually terribly undiagnosed, obsessive compulsive disorder. This is very, terribly undiagnosed general anxiety disorder. So I would say I do a lot of stimulant prescriptions, but I also see a lot of women with ADD and ADHD. But I do like Vyvanse. I think Vyvanse is great. Let's talk about testosterone. Currently, it is not recommended. It's not FDA approved for use in women in the United States. It's not recommended for anybody other than menopausal women with low sexual desire. For those of us who do women's health, we know that that's a load of hooey, but that's not what we're here to discuss. So testosterone therapy has been shown to be very beneficial for mood and cognitive benefits for women. It's also used as an adjunct for women who may be not good candidates for estrogen-based replacement therapy, or who have a lot of neuropsychiatric concerns that they're having. So don't discount the testosterone. Get a total testosterone level. That is one hormone level I think can be helpful to have a baseline and know where to start, because there is an index that we like to keep women in. And then transdermal delivery is the preferred method. You get 1/10 the dose that a man would need. We get a lot of the good female physiologic benefits and not a lot of the male concerns that can happen. Obvious things, engaging in regular physical activity is super important for mental health, but also just for our overall well-being. It boosts our mood, it creates a sense of community, it releases endorphins. We all know that yoga, walking, tai chi, swimming have been shown to be very effective at this phase in life, but I think any meaningful movement is good. So it doesn't have to be, oh, if you're not doing this, that's not good enough. Meet the women where they are, encourage them to continue to do what they're doing, and just continue to build on their everyday activities. Adopting a balanced diet. So eating the rainbow is super important. I know a lot of women will come in and say, I'm intermittent fasting, I'm doing Mediterranean, I'm doing paleo, I'm doing this, I'm doing that. I think that, all food should be accessible. It's hard when you start putting things off limits. But traditionally, if we're looking at cardiovascular health for women, we're going to focus on that Mediterranean diet. Next slide, please. Practicing mindfulness-based behaviors and relaxation techniques. We all know this, especially if you're in mental health. Taking those big, deep breaths, that reduces our anxiety, improving emotional regulation, talking with a friend, talking with your therapist. I think you can't replace that. Managing our stress. The world is very heavy right now. So I am seeing more people than ever coming with just feelings of heaviness, anxiety, fear about the future. So just helping, give strategies for stress reduction and creating, just that sense of calmness in your space that people are welcoming themselves into, your posture and your presentation to people. I mean, that's everything when you're meeting people for the first time and just helping them feel supported. And then lastly, just building that supportive network, helping, women to connect with friends and family, having good emotional Emotional support and just having that sense of belonging is just super valuable. And then sharing experiences with other women, that this is not singular. There are so many women, obviously 47 million women every year are going into this phase of life and knowing that you are not alone, and there are a lot of other women that are experiencing this as well. Next slide, please. And just key points to wrap up. 70% of women are going to come in with feeling anxious, depressed. That's going to be their initial concern that they are experiencing. Do not discount that. Either talk to them about mental health or have that be on the radar that there could be some hormonal concerns that need to be balanced. It may not be one or the other, but there might be, co-occurring conditions. Hormonal fluctuations pose a real concern to diagnosing and treating. My partner Candace and I always talk about this. Perimenopause is the hardest phase of life to treat because it's a moving target. Menopause, much easier. Other factors in life can be a lot easier. So just being open that when women come in and say, I feel like I can't lose weight, I feel like I'm gaining weight, that we don't say, you need to eat less, you need to move more, you need to sleep better. I guarantee many of those women have tried that. And please be open to that and say, hey, let's have a conversation. I might not know anything about it, but now you have a resource. Now you know people who are happy to talk about this and have a lot of knowledge. Women who have mental health concerns, as we previously discussed, depression, anxiety, postpartum, other endocrine concerns are always going to be at a higher risk for mental health disruption. So please don't discount those women when they come in and say, I think I'm fine, I think it's just this. Be really aware of that. And don't be afraid of HRT. It is not scary, something that you want to use. It's a viable option for lots of mental health concerns that are out there, but it should be used in conjunction with traditional mental health treatment if it is required to help women go through this perimenopause and menopausal transition. I think there's one more question, Shannon, if I can answer it real quick. Is that okay? Okay, Candace, I might need you for this one. T-gel choice. This is coming from Brian. Again, currently using 50 milligram per 5 ml gel tubes, same ones men use daily, but having women use 1 to 2 daily for 1 tube per week. Can pay $100 for 30 weeks of therapy. Know any cheaper options? Yeah, compounding. Get it compounded. Compounded, it's like 35 to 40 bucks and lasts like 3 to 4 months.
I think it's really hard because I feel like a lot of my patients do get flack too when I try to send it, or if I try to send something that's a 30-day supply for a male, it's a 300-day supply for a female. And I just feel like they get a little bit of flack. I'm not a pharmacist. They're not a pharmacist. I give them a little packet and I say, hey, try to make this packet last for 10 days. And that's hard to do. We've got a couple of really good compounding pharmacies in town. It's just nicer to be able to dose it off of that. And then it's less anxiety provoking for a patient too, to go, did I do a 10th? Is it, and it's the compounders really it's pretty inexpensive. I would say a 90-day supply is maybe $40.
Mm-hmm. I hope that answers your question, Brian. Wait, Candace, come back. I want you all to see this person. So this is Candace Inman. She is your local menopause certified hormone-based replacement therapy individual. Very, very smart, very good
Hi,
provider.
Candace. I have a bunch of patients who have seen Candace. I don't know if
Awesome.
we may have shared patients too, but
Yeah.
you've been very helpful and I appreciate you guys so much.
Thank you.
Wonderful.
Thank you.
Question. Which compounding pharmacy are you getting such cheap prices at? Because the ones I'm using are a lot more than that.
I use MedSync a lot.
Mm-hmm. MedSync,
I feel like Portico is one of the more expensive ones.
Yeah, Custom Medica, I feel like is really good, and their pharmacist is super nice to work with. He'll call me and say, hey, this person wants, compounded progesterone, and she's really nervous she's going to have a reaction, so I'm going to give her 4 capsules. I'm going to give her 4 days worth. So very, very, very cool to work with.
Okay, because I'm getting prices quoted like 50 to 60 a month.
I have not found that to be the case.
I usually write for a 90-day supply. It's usually like the Toppy Click that I write is usually a 90-day supply.
Okay.
Yeah.
I'll have to call around.
And yes, Misty, we will make sure that you have the contact information that you're asking for.